So, hi everyone who's there. I'm Sarah. I'm one of the anaesthetic CT3s. I've just got a brief presentation on an ICU audit that I did with one of the ST5s and medical student Tristan, who's going to be presenting a little bit after me. We've been looking at documentation of the RASS score in Glenfield ITU that we commonly use and is on the daily review charts. So during this presentation, I'm going to talk through the results of what I found through the audit and what changes I'm going to implement, and then we're going to do a little bit of teaching on the RASS score and what it means and how to use it as well. We're going to try and keep it brief because I know there's a presenter after us, and so any questions we'll do at the end if that's okay. So why did we choose to audit this? So the reason that we decided to audit this is because there is a guideline in UHL titled Delirium, the Delirium Guideline, and it talks about how to sort of manage delirium, agitation and pain. It's a really well written UHL guideline, but and the RASS score is only a small part of it, but generally we found that people aren't really documenting this part of a patient's daily review chart, and we wanted to understand what the reasons behind it were and whether we could improve documentation from this point of view. So we accepted our standard as 100% compliance because the guideline that I've got there said that every ventilated patient should have sedation target documented in their notes, and that should be based on the RASS score, the Richmond Agitation and Sedation score. We chose to look at every sedated patient rather than every ventilated patient, purely because we wanted to catch as many patients that were on sedation as possible, and any patients that would need sedation holds. We felt this was appropriate. So the reason we wanted to do this was also because, as we'll talk about in the later on presentation, agitation and delirium is a barrier to patients getting out of intensive care. It worsens their patient stay and their patient outcomes. And the point of these scores is to try and guide clinicians to reduce medications and therefore reduce the iatrogenic injury to the patients in that way. So the main three headings that I looked at was, does the clinician document the RASS score at the time of the daily review? So most of the daily reviews happen in the morning for patients, and then we looked at whether a target RASS was documented for sedation or anything. So we looked at either the number, or we looked at something like, has it been written to do a sedation hold? We later on decided that we couldn't include sedation hold because it wasn't clear, and so we felt that it had to be made even more clear. Also, based on the guideline, we felt that it had to actually document a target RASS. We also then decided to look at the grade of clinician that was performing the review, because within ICU we have a whole range of doctors, varying grades all the way from foundation. We've got different disciplines, medics working, as well as anaesthetic trainees and ITU trainees, and we've also got ACCPs over at the Glenfield. I'm not sure about LRI, so we decided that we would collect this data as well. So our methodology involves 7 non-consecutive random days, which we chose over June and July. All daily reviews of patient under sedation were looked at, and our inclusion criteria was just basically any patient who was on at least one form of sedation agent as an infusion. So about our results. So within our measures, infusion. So really loud. So the majority of patients were on a propofol infusion, primarily for sedation, but we did also include patients that were on remifentanil or clonidine or alfentanil or dexmedetomidine as well. So we found with our results that largely this is undocumented, and no accounts for the majority of whether it's documented at all on the daily review chart. It was varying in other, so I've also sort of highlighted what the score was, so how many people were highlighting yes and documenting -1, all the way through to -5 even. But one person had documented obeying commands, which we then excluded because it wasn't specifically looking at is the current RASS being documented. A target RASS being documented on the daily review within sort of the when in the sort of the finalizing bit at the end of the chart. Also, there was nothing really written by anyone there, and we found that the majority of targets were undocumented. We then looked at the grade of clinician, and SPR was the most recurring review, which fits with how we run the unit. Really, it's mostly SPRs and fellows who are doing reviews, and ACCPs. There were some ACCPs included in this data as well. It was a little bit concerning that there were quite a few charts that were unclear who was documenting there, and that might be because I just couldn't read it. But if I couldn't read it, I didn't include it as SPR or fellow or ACCP because it could have been anyone really. So there was nothing there to say this has been done by consultant all the way down to F1. So looking at the data and the spread of data, our conclusion is that SPRs and fellows are not doing so well with the documentation. Looking at ACCPs, they were managing to document the current score and target score 60% of the time. So they're doing really much better really at documenting these particular parameters, and that we have had to think about why that might be and what we can do to improve our own documentation as doctors. So our suggestions for improvement. So I think there needs to be an element of education and teaching, which is why we're going to talk a little bit about the importance of the score afterwards. We have proposed a review, an update to the daily review sheet. On the other side of the sheet at the bottom, there are things like target PO2, target saturations. We could include a target RASS in there as one of the parameters, although it wouldn't be applicable to each and every patient. The vast majority of patients that are coming to ITU will at some point have some sort of sedation, so it could be possible to do that. Our plan is to re-audit this in a few weeks to see if practice has changed, and then possibly to expand it and look at LRI as well, and see if it needs to be addressed more sort of cross-site. Our thinking with why the ACCP data looked so much better than the SPR and fellow data, we think it's because of the rotational nature of our training really, and that because as anaesthetists or IMT trainees, we're actually not in the department for that long, whereas ACCPs are in the department for a long period of time, and their training focuses very much on how to review an ITU patient. And perhaps one of the things that we would implement is some brief teaching at the beginning when doctors are being inducted into the department, as to why these parameters are important, and to just emphasize that. I think that is the end of my presentation. I'm going to pass over to Tristan now, who's going to talk about the RASS score a little bit.
So yeah, so I'm doing a quick presentation. I'm one of the fourth year medical students at Leicester. So in regards to what RASS actually is, as we said earlier, it's the Richmond Agitation and Sedation Scale. It was developed in 2001, 2002 by an American team, led by Curtis Sessler. It was designed mainly as a system to kind of assess sedation in ITU patients, whether on too much, whether it needs to go up, based on basically just how they're presenting. So there's lots of similar systems that use very similar terminology but are scaled slightly differently. So the Ramsey scale reads very similarly. So does the sedation agitation scale. The Comfort and Comfort B systems were designed mainly to aim for pediatric populations. The CAM-ICU is the confusion assessment methods for assessing specifically confused patients in ICU. Motor activity assessment scale aims to kind of look more at patients' motor activity. And then also there are kind of more tech-driven systems, so ones that look at EEG traces, bispectral indexes, and things like that. But obviously they're a bit more expensive, and running those for every patient might not always be possible. So this is the scoring for RASS. I won't go through all of it, but essentially it runs from a +4 to a -5, where the higher it is, the more agitated the patient is. And at the bottom, it says to aim for a default RASS of 0, so alert and calm, to a light sedation at -2. So in order to take a RASS, it's first of all about like patient observation. So is that patient very obviously displaying aggressive or competitive behavior, or are they drowsy? Patients that then aren't alert without kind of by themselves, you can go up to the patient, call their name to assess whether they're opening their eyes and whether they're doing that for a prolonged period of time or not. If the patients, even to their name being called, aren't responding, then kind of a physical stimulation like sternal rubs or shaking the shoulders is a possibility. That will be more clear with the rest of the scores. In terms of kind of comparing RASS to other systems, the one that's also commonly used is things like GCS. RASS is much simpler than GCS. It's a single metric rather than like a 3-metric system. Again, with GCS is mainly designed for patients with kind of a neurological or intracranial process going on, whereas RASS kind of deals with sedation more so. Aiming for that RASS score of -2 to 0 has been shown to reduce mortality, duration of ventilation, and also length of stay in ITU. So obviously it's very important for patients to kind of have good measurements on their sedation, and RASS is a good score for it. And again, it decreases the amount of sedatives that are used over time in these patients. And also, it's got very high inter-rater reliability. So if one person goes up and assesses the patient, it's very likely that someone else going up will get the same score. In terms of cons, if patients have limited auditory or visual, so they've got impairments in those systems, eye-opening and or calling out to a patient isn't going to be particularly effective. Compared to GCS, again, it's a single metric. So whereas GCS provides the 3 different metrics, you just get a single number with RASS. So because it's mainly designed to measure sedation, it doesn't necessarily predict outcomes in patients, which you might use GCS to do a bit more of. And it's also less reliable in patients, again, obviously with the auditory and visual things, but also if they have an altered baseline. So if they've got an underlying dementia or psychosis, or some psychosis related to drug misuse, personality disorders where they could become outwardly aggressive, or learning disorders again. So yeah, I don't mind talking about this, Sarah, if you wanted to talk about this bit, but
I'm happy to talk about it. So we just thought we'd add this slide. It's more sort of referring back to the guideline, which goes through how you would assess for delirium, pain, agitation a lot better, and then has lots of sort of flow charts which are really useful to kind of direct what pharmacological agents you're going to use. But essentially, as Tristan's already kind of said, once you've assessed a patient's pain level and you've prescribed and administered analgesia, that might be enough to solve the problem of agitation within the patient. But then if there is persistent agitation, that's when you would add in a sedative agent. As we found in our audit, and as per the guideline, the most common one is propofol, and I've included the flowchart there, and then depending on the RASS score, how you titrate the propofol. I'm not going to go through each different drug. I would just refer you to that guideline because it will explain it much better than I can. But then if propofol, although it's highly effective for short-term sedation and short-term ventilation, there are reasons why you might want to switch the patient onto a different sedative agent. So if you're going above 4 milligrams per kilogram per hour of propofol, if the patient is having hemodynamic instability because propofol does cause a reduction in MAP and cardiac output, or if there is evidence of propofol infusion syndrome, then you would consider perhaps adding in a different agent. Some of those are there, alpha-2 agonists such as clonidine or dexmedetomidine. So clonidine works in an opiate sparing way by stimulating opiate receptors, and it does need to be used with caution, and can cause withdrawal if it's suddenly stopped. Another option are benzodiazepines, such as midazolam, although because it has a active metabolite that accumulates, would be used more on a bolus basis rather than an infusion, in which case you'd need ICU consultant input if it was to go onto an infusion. I think back to you, Tristan. I think that's everything.
So that's everything I kind of want to talk about. These are some of the references I used. There's a really good MD Calc kind of page for it as well, which just makes the whole process a lot easier as well for taking a RAS. So yeah.
Cool. Thanks, guys. I can't remember if they have the same charts that we do at Glenfield. I haven't been there for too long, but
Slightly different.
I think they are slightly different. On the back of ours, you can flip it up and it tells you how to do the RAS scoring on the back, so you don't have to remember it all.
Yeah.
I don't know if you guys, if they have that again.
I think on the big impact charts they do. This is more we weren't looking at the nurses' documentation, we were looking at the daily review sheet, but that you could just flip over.
Sorry. Lost joined in the meeting. Thank you. What was I going to say? The other thing I was going to say, we did a similar thing, maybe Chang did a similar audit here in May, June time. And yeah, our documentation is not great either. We don't have ACCPs over here, but it was similarly bad, so we don't look at it very much. We try and do it, the nurses do it twice a shift, or theoretically, well, twice in 24 hours, once each shift. And do CAM ICU as well.
Mm-hmm.
But yeah, it's not really reliably done. And that she's doing a bit of work on sedation holds and documentation of sedation holds, and trialing a sticker to try and give. What used to happen is the nurses would be empowered to do sedation holds on a daily basis, but a lot of our nurses left after COVID. We've got very junior nurses who aren't confident to do it. So trying to empower them to go down the checklist, and if their patient meets all the criteria, then they can start doing it basically, and then document what the response was to sedation holds, whether the patient was appropriate or not.
Okay.
So it might be nice talking to her and kind of
we're going to brainstorm a little bit and talk about what we can do together. But I did see her, and we did have a brief chat in between cases. It sounds like if you're also having the same issues with documentation, perhaps it's more of a I don't know, maybe do you do anything in the induction at LRI, sort of when doctors rotate? Do you talk to them about it?
There is a sedation section in there. I can't remember. I think we say we use it. I don't think I do any more than that. So maybe we do need to do a bit more than that. Because
yeah,
there are people that don't really know what it is, but yeah, we can do them. Cool. Did you get questions? Yeah. Head shaking at me. Sorry.
Right.
Cool. Thank you very much.
Thank you.
So I'm just presenting a journal today, which talks about dexmedetomidine for the prevention of delirium in adults admitted to the intensive care or a post-operative unit. So it's basically a systematic review consisting of a meta-analysis of many trials done mostly in Copenhagen and through the Chinese database. Apologies to start off because it's quite a dry and statistical topic, and some of the slides are busy. Sorry. So delirium is characterized by changes in cognition and consciousness, with a decline in attention and focus due to fluctuating cerebral dysfunction. It is quite common in the critically ill, with reported prevalence between 25 to almost 90% in various intensive care units. Patients who develop delirium are at an increased risk of mortality, longer duration of mechanical ventilation, ICU, and hospital stay, death after discharge, and development of cognitive decline and even dementia. So delirium can be precipitated, like in patients who are having a brain ischemia, which can lead to blood-brain barrier, the breakdown of the blood-brain barrier, or it may be predisposed by drugs like benzodiazepines that alter the neurotransmitters. It can be due to acute withdrawal of drugs, alcohol. It can be for patients who are coming in with sepsis, presenting for emergency surgery, and more like that. Dexmedetomidine is still quite a new drug. It is an alpha-2 agonist. Mechanism of action is that it acts on the alpha-2 receptors. So the alpha-2 receptors are G protein inhibitory. So they inhibits the release of NORAD from the presynaptic neurons and leading to postsynaptic inhibition, which can result in sedation, which mimics normal sleep. It can lead to good amounts of analgesia. It also decreases pain, also decreases nausea, neuroinflammation, and it is also shown that they can decrease the ICU length of stay and mechanical ventilation. Because it's all in low levels, it can be a conscious level of sedation. It improves communication between patients and caregivers compared to other sedatives. Thereby, it can be said that dexmedetomidine may decrease precipitating and predisposing factors for delirium, which is the hypothesis for this paper. So they hypothesize that Dexmed would reduce the incidence of delirium and thereby potentially decrease the risk of serious adverse events and mortality. The primary aim was that they compare Dexmed versus placebo, no intervention or usual care for the prevention of delirium in adults admitted to intensive care, both planned and unplanned. And the secondary aim was to find out the risks of serious adverse events associated with Dexmed infusion. So they defined the serious adverse events like any untoward event that resulted in death, any life-threatening event that required hospitalization or prolongation of the existing stay, or that resulted in any significant disability. Materials and methods. So this is a systematic review. It was conducted according to a published and registered protocol, and it was reported with the help of something called a PRISMA, which is preferred reporting items for systematic reviews and meta-analysis. These all are well protocolized and well published from other previous work. Eligibility criteria. All the random control trials randomizing adults who got admitted to the intensive care or post-operative care unit and were compared with dexmedetomidine versus placebo or no intervention with a minimum follow-up of 24 hours. So this is the PRISMA protocol. So they basically go through the records, identify the records through the database, and then they screen the records, remove duplicates, screen them for eligibility criteria, then they match the trials according to the inclusion criteria set for this study. So the outcomes that they were looking for, primary ones were the occurrence of serious adverse events, occurrence of delirium, and all-cause mortality. Secondary outcomes, days alive without delirium within 28 days, quality of life, severity of delirium, and cognitive function. So they also did a reporting on the serious adverse events. Because the reporting was very heterogeneous and no trials reported according to the international guideline for good clinical practice, they decided to analyze it in two ways. First, they chose the most frequently reported adverse event, and they also accumulated the adverse events into different groups. They made some changes after publishing their abstract. So they included a more broader population of patients, not only intensive care patients. They also started including patients who are undergoing emergency surgery, elective or emergency cardiothoracic surgery, because these patients are also quite prone for delirium. They also did some subgroup analysis of trials, which included patients with a mean age at or below 65 years versus trials which included patients above the age of 65 years. The reason of this, I'll come to it very soon. So they assessed the records and removed duplicates. They included randomized control trials that reported at least one primary outcome. Then they included trials that had at least one arm as a no intervention or placebo as a control arm. And for the adverse events, they tried to exclude all the trials that are a high risk of bias or randomization concerns. So regarding results, for SAEs, the SAEs were reported in 80 trials, out of which only 5 trials were at low risk of bias. The highest proportions of SAEs, so the most frequently reported side effect was hypertension, followed by bradycardia. In the trials which had a low risk of bias, the proportion of participants with one or more adverse effects was 8.8% in the dexmedetomidine group versus 14.5% in the control group. The meta-analysis did not show any conclusive evidence of difference between Dexmed and control, which is a good thing. So Dexmed did not show any increase in adverse effects. For all trials, when they tried to accumulate the side effects, they found that dexmedetomidine apparently had less side effects, 39.1%, compared to placebo or no intervention group, which is around 47.2%. However, meta-analysis again showed no difference. Occurrence of delirium, once they excluded the trials which had a high risk of bias, it showed that delirium occurred in 10.9% and versus 16.2% in Dexmed and control groups. Meta-analysis did show there is a beneficial effect. All-cause mortality-wise, there was no conclusive evidence showing that dexmedetomidine had any benefit or worse than the control groups. They also did the subgroup analysis. This was mainly done because there was a trial called a SPICE-3 trial a couple of years back, which showed that dexmedetomidine kind of increases mortality when used in participants less than 65 years. In this trial, it also showed similar results in patients less than 65 years. But when they decided to exclude the ones that were included in the SPICE-3 trial, it shows that there was no difference in mortality in patients less than 65 years. And when they did the same calculation for patients more than 65 years, even when SPICE-3 trials were included, Dexmed seemed to reduce the mortality. Coming to secondary outcomes, they used the WHO quality of life protocol and it kind of showed that the dexmedetomidine has a beneficial effect on physical, psychological, and social relationships. Again, for cognitive function, they used one trial. There were very few trials that used that monitored the cognitive function. One trial used MMSE scale, other ones used the MTIC scale, and for both, there was no such major difference to prove that Dexmed was beneficial. So, summarizing, when they included all the trials, Dexmed kind of showed a reduction in the occurrence of serious adverse events, and it also can lead to occurrence of delirium and mortality. The reviewers used something called a trial sequential analysis, and the evidence regarding what I'll say, the recommendation actually came out very low. But this review did have some strengths, like they used very well published protocols from the Cochrane handbook. They used the trial sequential analysis to account for any increased risks and random errors. They tried to assess the certainty of evidence using grade. And limitations-wise, I felt that because they included all patients as a post hoc measure, these patients were at high risk of developing delirium, and which makes them also susceptible to the side effects of dexmedetomidine. Again, the broad inclusion of patients makes it very clinically diverse. They did not mention of any implication of that diversity. There is a low incidence of mortality in the trial, which they also accepted. However, in our typical ICU population, the mortality numbers are quite high. So that's kind of a difference between this trial and a typical ICU population. But when they tried to assess the incidence of all-cause mortality based on all the trials, even which had a high risk of bias, that was kind of similar to an ICU population that we can see. And most of the results, again, were at a high risk of bias. Even the ones that were favoring dexmedetomidine has small study bias. So I just want to touch a little bit on the SPICE-3 trial. So it was done in 2018, 2019 throughout 8 countries, including Europe, Australia, New Zealand. And they showed that there was an increased in absolute risk of mortality of 4.4% when using Dexmed in patients aged less than 65 years. This led to the European Medicines Agency to issue a warning regarding use of dexmedetomidine as a sedative drug for infusions last year. So this review, as I was saying, found that when they tried to exclude the studies that were included in the SPICE-3, the trials, they did not find any evidence of a harmful effect. Furthermore, in the subgroup, both the side effects and the delirium seem to be reduced. Therefore, which is quite conflicting regarding the increased mortality in the subgroup less than 65 years. Both in SPICE-3 and in this trial, they did not mention any mechanism of the potential increase in mortality. And however, the good thing is there was a 39% relative decrease in risk of mortality in patients more than 65 years of age, when even trials which were included in SPICE-3 were analyzed, and there was a 49% relative decrease when the trials included in SPICE-3 were excluded. So what I understood from this paper is that dexmedetomidine seems to be a beneficial in reducing the occurrence of the adverse effects and possibly delirium based on the trials, which are at a low risk bias. And if you consider all the trials, then the numbers really look good. However, the effects on mortality at low risk bias were quite uncertain, So they have produced good numbers, but the quality of evidence is low. And from subgroup analysis of all trials, it seems that dexmedetomidine is particularly useful when it's used intraoperatively in elderly patients and in patients undergoing surgery with a planned intensive care admission. However, this needs to be confirmed with adequately powered trials at low risk of bias. This paper piqued my interest into looking into trials where dexmedetomidine has been used intraoperatively. I tried to look at a few, I couldn't find much on it. So that may be a potential area of research later on. And especially because dexmedetomidine, I believe, has become much more cheaper than it was because of patency has ended. I think that's it for me. Thank you.
Thanks, Shamit. I'm not aware of it being used intraoperatively.
As
really.
part of cardiac surgery.
Yeah, it's bits in heart, but not.
It's cardiac surgery, the highest level of this intraoperatively in the area of elective cardiac surgery.
Yeah.
Many in the US actually trying this like that. Studies, small studies that are not powered enough to show anything.
Did you hear that?
Kind of, yeah.
Yeah, so there's bits, small studies in America and China that have used dexmedetomidine in cardiac surgery, but not much more than that yet. I know I've not done it myself, but I know there are a few people that have been using it for awake fiber optics instead of Remy, whatever. I've not tried that. I don't do awake fiber optics very often. Has anybody tried that? No.
Exposure in an awake fiber.
Yeah. No. And it has been used in peds a bit as an alternative sedative method. But yeah, we do it. To be honest, we tend to use it in the younger patients probably than the older ones actually. Yeah, there's not much evidence either way, really, is there? But yeah, we tend to use it for the difficult ones that have failed other stuff because it's more expensive, or the ones that, or sometimes we do it for the ones that we're going to predict are going to be difficult, and we'll switch them to Dexter or trying to wake them up.
Yeah.
So how is it your article going to change your practice then, do you think?
So to be honest, the only thing I won't use it as a first line, I would say. Again, as you said, mostly if something is not working or they are on a trachea requiring some sedation because they're very delirious, maybe dexmedetomidine may be used. I would be a little bit cautious after reading this article because the European Medical Agency has issued a warning. Yeah, but I would definitely want to see more trials where intraoperatively, I think, if it's getting used. Yeah. And that's pretty much, I think, yeah.
Yeah. There are still going to be more trials. There's always need for more trials. It's always the answer, apparently. We're doing one at the minute of propofol versus clonidine versus Dexter, which we've been going.
Long time.
It's been going for years.
COVID delayed.
And I think they're getting towards the end.
Yeah.
A to B is cool.
I dug a little deeper, and I kind of think that this article or this review was done to make Dexmed look good after that warning came out. And one of the researchers are actually having one of the researchers also have an affiliation with Novo Nordisk. So yeah.
Yeah.
I don't know.
Anyway, it can be useful. It does work for some people, but in the same way as other things, it doesn't work for everybody.
So when I was in India before I came to this country, because it was very cheap. Dexmed was very cheap in India. People were using in intra, but without what I'll say proper research and that things like that. But people were in general quite happy with the outcome. It's almost like using remifentanil.
Yeah. It is a lot cheaper than it used to be.
Yeah.
So our pharmacist is in the room and he's a lot happier with us using it than he was in company, isn't he?
I think it's important to know that nurses aren't the biggest fans of the program, because I think, rightly or wrongly, it's not better the patient to be slightly more sedated. And dexmedetomidine often means the patient is not as sedated as they would like them to be, and it can be difficult.
It does make the nurses, we like them to be more awake. The nurses don't like it. As I'm sure Sarah's found with doing the audit, RASS scores are lower than they need to be a lot of the time.
-3 all the time.
Yeah, exactly. We like it to be.
I think it's a challenge, especially with our nurses or workforce sometimes. When they're more junior, they realise that it can be difficult.
Yeah, definitely. Thanks, guys.
Thank you very much.